We will now proceed with our next session on acute and subacute stroke therapies. To introduce the speakers is our moderator. She is a member of the Stroke Council of the Philippine Neurological Association and is the president of the Stroke Society of the Philippines, South Luzon chapter. She is the program director of the Brain Institute in the Asian Hospital and Medical Center Hospital. She took her residency training in adult neurology in the University of the Philippines, Philippine General Hospital, and her fellowship training in vascular neurology at the National Neuroscience Institute in Singapore General Hospital. She is currently affiliated with Perpetual Help Medical Center in Las Piñas City, Medical Center Manila, and Asian Hospital and Medical Center. Ladies and gentlemen, let us all welcome our moderator, Dr. Jennifer Justice Manzano.
Hello, good afternoon, everyone. I'm very happy that you can all see me. Not every day, or usually when I'm invited to speak, yung top lang ng head ko ang nakikita niya. But I'm very happy to see you all clearly, and I'm happy that you can see me. So, good day. It is my pleasure to introduce the next session entitled Acute and Subacute Stroke Therapies, which highlights the latest advances in treatment strategies from adult to pediatric care, and which brings together leading experts who are shaping the future of acute stroke management in the Philippines. Our first speaker is a dedicated clinician and leader in stroke care in southern Mindanao. She completed her residency training in adult neurology and internal medicine residency at the Santo Tomas Hospital for Neuro and at the Southern Philippines Medical Center in Davao City for IM. She is a fellow of both the Philippine Neurological Association and the Philippine College of Physicians. She currently serves as the Assistant Training Officer for the Adult Neurology Residency Program at the SPMC and serves as the President of the Stroke Society of the Philippines, Southern Mindanao Chapter. We are honored to welcome Dr. Julie Ann Kristy L. Torres, who will present her lecture, Optimizing Stroke Systems, Tailoring Pre-Hospital Triage Scales to Philippine Realities. We ask Dr. Torres to sit in front. Our second speaker is a recognized authority in acute stroke care. She earned her Doctor of Medicine degree from the UP College of Medicine and completed her residency and fellowship in stroke and cerebrovascular diseases at the UP PGH. She currently heads the acute stroke unit at the PGH, serves as co-clinical director of the Neurovascular Center at the Cardinal Santos Medical Center, and is the training officer for the UERM CSMC Adult Neurology Residency Training Consortium. Palagi ko po itong rene-request na mag-cover sa akin kapag may sakit ako. Please welcome Dr. Lennie Lynn C. de Castillo, who will deliver her lecture, Thrombolysis in Transition, Comparative Evidence on Alteplase versus Tenecteplase in Philippine Stroke Care. Our third speaker brings both local and international expertise in neurocritical care. He is a medical specialist too at the Baguio General Hospital, the department head for neurosciences at the St. Louis University School of Medicine, and a visiting lecturer at the Pine City College's School of Medicine. He practices adult neurology at the Medical City, where he completed his residency in adult neurology. He is trained in neurointensive care at the Addenbrooke's Hospital at the Cambridge University Hospitals in the UK, and currently heads the intensive care unit at the SLU and the neurocritical care unit at the BGH. We are privileged to hear from Dr. Manolo Kristoffer C. Flores, who will present his lecture, Early Neurocritical Care, Precision Management of Reperfusion Injuries in the First 48 Hours. So hindi lang naman adults na stroke, even even kids get a stroke. And we are very happy to present our fourth speaker, who is a pioneer in pediatric stroke and neurocritical care. He completed his residency in pediatrics at the University of Santo Tomas Hospital, followed by a fellowship in pediatric neurology at the UP-PGH. He pursued further subspecialty training in pediatric stroke at the University of Toronto's Hospital for Sick Children and in pediatric neurocritical care at the University of Calgary's Alberta Children's Hospital. We are honored to welcome Dr. Elbert John V. Layug, who will present his lecture, Redesigning the Blueprint, Navigating the Unique Landscape of Pediatric Ischemic Stroke. As a reminder to everybody, throughout the lectures, a QR code will appear, flash on the screen. We encourage everyone to scan the code and send in your questions. And we also encourage you to ask live questions later on through the microphones that you see around. All your questions will be answered during the open forum after all the lectures have been delivered. And now, to begin the session, may I call on our first speaker, Dr. Julie Ann Kristy Torres.
So good afternoon, everyone. I hope you had a fulfilling lunch. So for today, I'll be tasked with discussing the first part of this session. So stroke remains one of the leading causes of disability and death in the Philippines. So in 2020, I'm sure you already know, the government, through the Department of Health, approved the National Stroke Policy. Now, the goal of that is to deliver timely and quality stroke care for all Filipinos. However, this policy focuses mostly on hospital-based readiness, like, for example, the establishment of the acute stroke-ready hospitals. So, as well as also the integration of what we call the healthcare provider network. But however, it fails to address one of the problems in our country, which is the emergency medical services. So as you all know, our counterparts in Asia already have their established EMS, but for the Philippines, we do not have a unified EMS. So my goal today is to discuss the role of EMS in the continuum of stroke care, as well as the utilization of the pre-hospital stroke scales in the triage of suspected stroke patients, and the current landscape of pre-hospital stroke systems of care in the Philippines. So, as mentioned earlier by Dr. Belen, time is brain. So this is a phrase coined by Dr. Jeffrey Saver in 2006. So it emphasizes that there is rapid quantified loss of neural tissue during an ischemic stroke, with around 1.9 million neurons lost every minute and premature brain aging of around 3.6 years every hour without timely reperfusion therapy. So the stroke care continuum, as summarized by the 2026 guidelines, encompasses the full course of the emergency evaluation, as well as the early management of patients with acute ischemic stroke. Now, this would include the earliest interaction with pre-hospital systems, so in particular, the emergency medical services, as well as the evaluation, treatment, and in-hospital management of patients with acute ischemic stroke. Now, I'd like to emphasize that we have to define the pre-hospital phase. So this is the critical window from the onset of stroke symptoms to the hospital arrival, and this will be facilitated by a very organized emergency medical system. So, as you all know, numerous trials have already shown that administration of thrombolytic therapy or even the performance of mechanical thrombectomy prevents disability from stroke. Hence, pre-hospital coordination is crucial for the timely treatment of patients with acute ischemic stroke. The latest guidelines from the American Heart and American Stroke Association recommends that regional stroke coordinating bodies must ensure that healthcare provider networks are organized in a way that identifies hospital capabilities for stroke care, as well as implementation of stroke systems of care which is equitable for the entire population. It's also important to note that mandatory hospital pre-notification to activate the stroke team before arrival of that patient should be considered because it really works even for our city. So with the emphasis of emergency medical services as a critical component in stroke care, policy should be in place for a unified national EMS here in the Philippines. However, 6 years since the implementation of that national stroke policy, the Philippines still lacks a unified EMS. So it lags behind our counterparts such as, for example, Thailand, Vietnam, Singapore, Japan, and South Korea. Local government units and barangay health units have a limited number of ambulances. For our locality, what we have are the patient transport vehicles. I'm sure you also have that. To transport patients, however, they do not have protocols for field triage as well as standards of care or even communication with the receiving facilities. There are also resource gaps such as, for example, the lack of neurologists in geographically isolated areas as well as the lack of infrastructure, even Wi-Fi connection for telemedicine or telestroke. They may also contribute to decreased delivery of timely stroke care. Now, pre-hospital triage protocols should be established at the regional level. Now, we have to employ the use of an appropriate pre-hospital stroke screening tool as well as other protocols for transfer or direct transport to the nearest most appropriate facility or what was enforced as the right door policy. Now, in our setting and with the National Stroke Policy, we have what we call the acute stroke-ready hospitals, or even those thrombectomy-capable centers. So, as you can see in this table, and for the next few slides, this is a summary of all the pre-hospital stroke scales that are published in international as well as local journals. So, the first one is very familiar to you, FAST, which stands for facial droop, arm drip, speech, and time. So mainly it's used for stroke recognition. So most of the scales that are presented here in this table are for stroke recognition. In particular, the Los Angeles Pre-Hospital Stroke Scale has been used because it has a very useful tool for ruling out stroke mimics. We also have what we call the BFAST, which includes balance and eyes into the FAST scale, and it has been used for posterior circulation stroke. The most commonly used worldwide would be what we call the Cincinnati Pre-Hospital Stroke Scale. And we also have the MAS, or the Melbourne Ambulance Stroke Screen, as well as the MEDPACS, or the Medic Pre-Hospital Assessment for Code Stroke. So some of these scales will mimic the NIHSS in that it also includes consciousness, gaze deviation, and even aphasia and neglect. So how about for LVO detection? So as mentioned earlier, you should triage a patient to an appropriate facility. If, for example, the screen is positive for left large vessel occlusion, then the patient must be directly transported or even transferred to a hospital that is capable for mechanical thrombectomy. So these scales would include RACE, or the Rapid Arterial Occlusion Scale. The cutoff score for this, for the detection of LVO, is a score of more than 5. We also have what we call the Los Angeles Motor Scale with a cutoff score of either 4 or 5, as well as the Vision, Aphasia, and Neglect Scale. Any one that is positive is already a detection of LVO. We also have GFAST, which is a modified BFAST in that it includes gaze deviation into the scale. We also have FAST-ED, which is a simplified version of the NIHSS scale, which is also used for detection of LVO. And then we have what we call a modified Chu-Chi scale. This one was employed in Taiwan. Now, this includes gaze deviation and consciousness as well as arm motor strength. So as you can see here, the cutoff scores can be either very low or very high. So how about the accuracy and application for these stroke scales? So we'll deal first with the CPSS or the FAST. Both of these scales are nearly similar. So the cutoff score here is just 1 or more. The sensitivity is quite high at 80%, while the specificity is around 34%. So how about the Los Angeles Pre-Hospital Stroke Scale? The sensitivity is lower compared to the CPSS at 66 and a very low specificity. So what's the problem if the specificity is quite low? You might over-triage patients, no? So the stroke mimics might be treated as stroke. We also have the race I mentioned earlier. So the sensitivity here is low for stroke detection, but if you use it for detection of LVO, it's quite high. This is similar to the Los Angeles Motor Scale, in which the detection rate for LVO is also high. So that there are 7 scales that are mentioned here in these slides, and that was from a systematic review by Decker and colleagues, which was published in 2025. The key findings from that head-to-head comparison of the 7 pre-hospital stroke scales is that the best performing scales, such as the MedPACS, a modified version of the NIHSS for emergency medical personnel, and the Ontario Pre-Hospital Stroke Scale demonstrated the highest accuracy and sensitivity, reaching more than 80%, making them the best for identifying patients requiring urgent treatment. Also, the worst performing scale was said to be the Los Angeles Pre-Hospital Scale. It's very low sensitivity and specificity, as well as low accuracy. However, if you are trying to more or less increase your sensitivity for detecting stroke, they recommend using several scales, not just one scale. But of course, that will limit the performance or the delivery of stroke patients, especially among the EMS. So the study concludes that utilizing more accurate scales, for example, the shortened NIHSS or the MedPACS, as well as the Ontario scale, can improve identification while reducing the over-triage of stroke mimics. How about in Asia? So in several countries in Asia, they have created their own pre-hospital stroke scales, or they have used the stroke scales which are used in the Western countries. So for example, in Taiwan, they created their own pre-hospital stroke scale, the modified Chu-Chi scale. Now, mind you, this is not the first scale that the EMS will use. They have to first use the CPSS for detection of stroke. This will be the second scale that we will employ to detect LVO. So the sensitivity is quite high for VAN as well as for Chu-Chi. And then for a country like, for example, Iran, they have the Cincinnati pre-hospital scale, FAST, MedPACS, and the LAPS. They have shown that for that setting for Iran, for example, the sensitivity of MedPACS is quite high, 95%, whereas in the systematic review by Decker, the sensitivity was lower. So it will depend as well on the training of your personnel as well as the cultural setting. How about for Japan? They created their own triage system. So we call that the Japan Urgent Stroke Triage. So they have used this one and partnered it with their mobile stroke units to perform pre-hospital thrombolysis. In China, they have their own validated Chinese version of the NIHSS, and they also employ the BFAST. So how about for our setting? So for now, we have only one region with a unified as well as organized Central 911, and I'm proud to say I'm from this city. So this is a picture of the Central Command Center of the Davao City Emergency Response Center. So as you all know, the dispatch number for this one is, of course, 911, similar to the one used in America. So this command center is at the forefront of providing primary emergency response services in the Davao City or sometimes in the nearby regions. So this was actually not meant for emergency medical services at first. No? It was a collaborative effort between the Davao Light Power Company to decrease the crime rates in the country, in the city, I mean. So they were trying to mark the light posts, for areas in which there were higher crime. But it turned out that through means of serendipity, this was also useful for emergency medical cases. So that's why for now, moving forward, they use that one for medical assistance for emergencies, even for search and rescue operations, fire suppression, as well as augmentation through its own K9 services. So this has been in at work no, for more than 20 years in Davao City. So, as you all know, similar to the Luzon and Visayas, we also have what we call our acute stroke-ready hospitals. So, we have around 6 in Davao City, and I'm happy to tell you that we have at least 2 hospitals that are capable of performing thrombectomy. And one of which is the government hospital, is actively performing thrombectomy since last year. And what do our EMS personnel use for stroke detection? We actually use only one for convenience, and that will be BFAST. So one of the residents of our training institutions, the Southern Philippines Medical Center, in particular the emergency medical resident, performed this study on the diagnostic accuracy of the Davao City EMS personnel using BFAST as an assessment tool or a pre-hospital stroke scale. And I'm happy to say that the results are quite positive. No? After training, the sensitivity for BFAST in detecting or recognizing stroke reaches around 94%, while the specificity is around 96%. So it's a very useful triage tool, especially for patients with suspected stroke. So in terms of numbers, this is already reflected. No? So this is the census of our stroke patients for the past 3 years. And our thrombolysis rate is quite high now. With the help of our EMS, we're able to detect suspected stroke cases and triage them appropriately, especially to the government hospital. So our government hospital has the thrombolytic available as well as the thrombectomy available. So how about for the national setting? So this act was already submitted, but it was promulgated in around 2017, but it has yet to be ratified into a bill. So I hope that in the coming months or years, this will be approved as a law so that we will have our own emergency medical system in the Philippines. So in conclusion, the emphasis should be placed on creating a unified emergency medical system in the national setting, because in the local setting, it actually really works. The pre-hospital triage using stroke scales has been shown to be sensitive in detecting not only stroke but also large vessel occlusion for proper triaging to thrombectomy-capable centers. And with that, I'd like to thank the audience for listening.
Thank you, Dr. Julie Ann Kristy Torres. And now let us welcome our second speaker, Dr. Lennie Lynn de Castillo.
Good afternoon, everyone. First, I'd like to thank the organizing committee for inviting me to speak today. I'm delighted to share with you the latest updates on thrombolysis and to introduce the relatively new kid on the block for acute ischemic stroke, Tenecteplase. My objective for this lecture is to compare Alteplase and Tenecteplase in terms of trial evidence, safety profiles, cost implications, and real-world implementation. We all know that stroke is the second leading cause of death worldwide, and acute ischemic stroke comprises around 80% of all stroke cases. IV thrombolysis with Alteplase has been here for the past 30 years, and it has been the standard reperfusion treatment for acute ischemic stroke since 1996. With the arrival of Tenecteplase, will it offer better outcomes? So now we will know. So why do we need a better alternative in the Philippines? In the government hospitals, we know that we lack resources. Infusion pumps, nag-aagawan pa yung mga bawat pasyente. We also lack manpower. We lack nurses to reconstitute the drug, to give the drug, no? Ilalagay pa niya sa soluset, ilalagay pa niya sa infusion pump, no? And also monitoring patients. They are the ones who are monitoring. Sometimes our clerks, our interns, even our residents monitor our patients. We have limited ER beds, so we want to transfer our patients as soon as possible to the acute stroke unit or to a monitored bed. And also, we need faster door-in, door-out time. As you will learn in the next lecture tomorrow would be thrombectomy, because we have thrombectomy now. So we want patients eligible for thrombectomy to be transferred to another institution capable of doing that as soon as possible. So now we should understand the two agents first before we discuss the efficacy. So, have you ever wondered why Tenecteplase is abbreviated as T and K? So, most millennials would agree with me na yung pag-abbreviate, it's important to us nung Nokia 3210 pa, di ba? Kasi 160 characters lang. And then, you have to fit your endorsement to the consultant in 160 characters. So, in Tenecteplase, you can abbreviate it as T and K. Bakit kaya yung Alteplase hindi ALT or ATP, no? Because Tenecteplase is actually a genetically modified version of the Alteplase. So, bakit T, N, and K? So, these are actually amino acids. So, T for threonine, N for asparagine, and K is for lysine. Okay. So, these amino acids, so yung T, yung threonine, at position 103 is changed to asparagine. So, you can see here dun sa image, no, nag-iba yung configuration nung molecule. And N, asparagine, is replaced by glutamine, so N, at position 117. And yung K is for KHRR, may 4 amino acids na naging alanine lahat. Okay. And these changes made Tenecteplase more, it made it more high fibrin specificity. Also, the plasma half-life also increased from around 5 minutes for Alteplase. It became 20 to 24 minutes. And also, the PAI-1 inhibition also is high in resistance. So that means that you can give the Tenecteplase as bolus. So instead of giving it as a drip of 1 hour, you can give it for 5 to 10 seconds. So that is a very important modification in the structure of Alteplase. And what are the doses? So for Alteplase, you give it as 0.9 milligram per kilogram, maximum of 90 milligrams. While Tenecteplase, you give it as 0.25 milligram per kilogram and maximum of 25 milligrams. Both of them are in the powder form, so you still have to reconstitute the Tenecteplase, but it's easier to get the volumes. Later, I'll give you the volume to be injected to patients. And then you administer Alteplase as bolus first, 10%, and the remaining would be administered as infusion for another hour. While in Tenecteplase, you just give it for 5 to 10 seconds, tapos na. So how do you administer Tenecteplase? So weight-based pa rin, but instead of calculating yung exact na dose, because 5 ml lang po yung maximum dose, no? 0.5 lang yung difference, depending on the weight range. So it's easier to remember. You can even put it in your IDs or in the station so that they have a guide on how to give it. So now let's go to the clinical evidence. There is a recent meta-analysis on Alteplase and Tenecteplase comparing its efficacy and safety in terms of in acute ischemic stroke. And for this meta-analysis, the included trials are all RCTs, and the patients are diagnosed or are enrolled are those within 4.5 to 6 hours. The intervention group should receive the Tenecteplase at 0.25 milligram per kilogram, while the control group is the Alteplase. And they should be reporting at least one predefined efficacy or safety outcome. So the trials are as follows. So it's listed there if you want to read them up. But I will present the result of the meta-analysis. So this meta-analysis was published last 2025. Okay, so the mean age, they included 7,546 patients, 3,788 received Tenecteplase, while 3,758 received Alteplase. The mean age is 64 to 76 years, and the mean NIHSS is 6 to 17, so in the moderate stroke range. 8 studies included patients within 4.5 hours, while 2 studies included within 3 hours. Then only 1 study included within 6 hours, and that is Parsons et al. Okay. Kaya may asterisk yung dalawa, original and attest to, because that is the most recent trials, no? 2024 sila na-publish. The primary outcome of this meta-analysis is excellent functional outcome, which is defined as an MRS score of 0 to 1. So what are the results? For the primary clinical outcome, as you can see in this forest plot, so the diamond, no, yun yung summary ng lahat ng trials, it favors Tenecteplase and it doesn't cross the line. So that means that Tenecteplase is superior to Alteplase in acute ischemic stroke. And you see the confidence interval does not also cross 1. How about for the good functional outcome? That's MRS 0 to 2. So here, you can see yung diamond medyo nag-cross nung line, ng vertical line. So that just means that there is no statistically significant difference between Tenecteplase and Alteplase in terms of good functional outcome. And this also is the same for early neurological improvement. We define early neurological improvement as more than or equal to 4-point reduction in the NIHSS score within 24 hours. So here, no statistical differences between the two, as well as mortality, all-cause death. So as you can see, the diamond is crossing the line. And for symptomatic ICH, there's also no significant difference. Poor functional outcome, so again, no difference. So with these data, what do our guidelines say? So I'll summarize some of the most commonly used guidelines. For the European Stroke Organization, last 2023, they made an expedited guideline that for patients with acute ischemic stroke, less than 4.5 hours duration, eligible for IV thrombolysis, Tenecteplase at a dose of 0.25 milligram per kilogram can be used as a safe and effective alternative to Alteplase at 0.9 milligram per kilogram. They further recommended that in patients with large vessel occlusion, they recommend Tenecteplase over Alteplase. So, because in 2021, there's a meta-analysis saying that in patients with LVO, the good functional outcomes are better with Tenecteplase than Alteplase. Okay, how about the dose of Tenecteplase? So they recommended against the use of 0.4 milligram per kilogram of Tenecteplase because of questionable harm for patients. And for patients with acute ischemic stroke, wake-up stroke, or unknown onset who are only selected with non-contrast CT, so they recommend against IV Tenecteplase at 0.25 milligram per kilogram. So there's no evidence. Kahit na mukhang safer yung Tenecteplase, you still cannot use this for patients na with unknown onset just with CT. Of course, if you'll use the MRI, that's another question. No? Okay. So how about our Stroke Society of the Philippines? So last 2024, they released our clinical practice guidelines. So among patients with acute ischemic stroke of less than 4.5 hours, they recommended the use of Tenecteplase as an alternative to Alteplase. And lastly, the most recent guideline would be our AHA and ASA guidelines. So AHA and ASA last 2026 recommended Tenecteplase or Alteplase. So it's an or recommendation now, to improve functional outcomes in patients with acute ischemic stroke. And again, they reiterated that we should not use the dose of 0.4 milligram per kilogram. How about the cost implications? Locally, there are no studies yet on the cost effectiveness of Tenecteplase, but there is one Dutch study. So in the Netherlands, they use the Dutch healthcare payer perspective. So sa Netherlands kasi, HMO yung patient pero they are monitored by the government. So clinical data were obtained from large RCTs and real-world data. And this study showed that treatment with Tenecteplase saved 21 euros per patient while gaining 0.05 quality-adjusted life years. So resulting in an INMB, so incremental net monetary benefit of 2,381 euros. So yung INMB, if it's more than zero, then it's cost-effective. So this study concluded that Tenecteplase is really cost-effective compared to Alteplase. And this study only checked the direct costs, no? Hindi pa kasama yung mga indirect costs. How about in our real-world data? So we only have one published data about Tenecteplase, and that is from the East Avenue Medical Center. And thank you for providing me with the paper. So they included 10 patients, 5 of which were large vessel occlusion, and the mean NIHSS is 15.6, similar to our meta-analysis. What's important here is that the mean door-to-needle time is 58 minutes. No? So I'm sure everyone would agree with me that it's very hard to target the 60 minutes door-to-needle time. And I think this study showed that Tenecteplase really is also beneficial due to the time limit. And the MRS of 0 to 2, that's good functional outcome at 90 days, is 70% in this study. So, my take-home points are, Tenecteplase has a longer half-life, higher fibrin specificity, and plasminogen activator inhibitor 1 resistance than Alteplase, allowing for a single bolus administration and decreasing systemic bleeding risk. In patients with acute ischemic stroke, Tenecteplase demonstrated a significant advantage over Alteplase in achieving excellent functional outcomes with similar safety profile. Therefore, in patients with acute ischemic stroke within 4.5 hours of onset or last known well, Tenecteplase is a safe and effective alternative to Alteplase. So these are my references. With that, thank you for listening.
Thank you, Dr. Lennie Lynn de Castillo. And now, let us welcome our third speaker, Dr. Manolo Kristoffer Flores.
Thank you very much for inviting me. It's truly an honor to be here. Today, I will be discussing precision management of reperfusion injury within the first 48 hours. For me, the most critical portion of treating patients with acute stroke after thrombolysis and thrombectomy would be, this is biased, the things that happen in the neurocritical care or after we admit the patient to the stroke unit. For this lecture, I do not have anything to disclose that is relevant to this topic. So during medical school, all I knew was that kapag may bara sa utak, alisin ang bara sa utak. It kind of made sense during that time. So this timeline shows the evolution of our thinking regarding acute ischemic stroke. In 1995, IV thrombolysis opened the reperfusion era and proved that early restoration of blood flow could improve outcomes. However, over time, we realized that in large vessel occlusion, IV thrombolysis alone was not enough. Because of this, there was an impetus to find other solutions. Trials in 2013, even though they were labeled as quote-unquote failed trials, taught us lessons for better imaging, faster workflows, and more effective devices. By 2015, these landmark trials showed that when we select the right patients, outcomes improve substantially. So we ended up with mechanical thrombectomy, not because IV thrombolysis doesn't work, but because of large vessel occlusion, pharmacologic reperfusion alone was often insufficient, and thrombectomy became the mechanical answer to a mechanical problem. Despite achieving successful reperfusion in the majority of patients undergoing thrombectomy, look at this, almost half still fail to reach functional independence. This has led to the concept of futile reperfusion, where macrovascular flow is restored but tissue-level recovery does not occur. The problem lies at the microcirculatory level, where no reflow, capillary obstruction, and endothelial dysfunction occur despite an open artery. At the same time, reperfusion propagates secondary injury cascades. Reperfusion injury is not a single event. It's a cascade of interrelated processes that begin immediately after flow is restored. At the microvascular level, we often see a no reflow phenomenon where there is capillary obstruction, and this prevents effective tissue perfusion. This is followed by the blood-brain barrier breakdown, leading to vasogenic edema. Simultaneously, we have a thing called thromboinflammatory pathways that are activated, amplifying endothelial injury and microcirculatory dysfunction. In some cases, this progresses to hyperperfusion, where dysregulated flow further damages vulnerable brain tissue. This is why it is important to intervene within 48 hours. Even after recanalization, infarct expansion can happen, driven by ongoing microvascular failure and secondary injury. In the first 24 hours, the dominant risks are hemodynamic instability and hemorrhage or hemorrhagic transformation. Between 24 to 72 hours, the focus shifts. We now talk about cerebral edema and the risk of neurologic deterioration. Importantly, this entire window is both detectable and potentially modifiable, making early neurocritical care as the key determinant of whether reperfusion translates into meaningful recovery. What do we do now? Well, in the NCCU, we usually define the targets, and we try to achieve the targets. In the next few slides, I will be talking about macrohemodynamics, cerebral physiology, and even cellular metabolic targets. Let's talk about macrohemodynamics. Among all the modifiable factors after reperfusion, blood pressure is arguably the most important lever that we have. Traditionally, we relied on fixed thresholds, such as keeping their blood pressures below 180 over 105. But this approach does not account for the strict underlying physiology. Emerging evidence suggests that over-aggressive BP lowering may be harmful. So much so, if you target so high that it will lead to hemorrhagic transformation. The current direction is clear. Avoid extremes and individualize blood pressure targets based on reperfusion status and tissue vulnerability. What does that mean? While current evidence still recommends blood pressure targets of less than 180 over 105, emerging targets suggest tailoring blood pressure to reperfusion status. In patients with complete reperfusion, such as this one that I'm showing, lower blood pressure targets have been suggested. That would be 120 to 140 millimeters mercury. However, this needs careful interpretation because some studies would still say that 140 to 160 millimeters mercury target would be best for these individuals. In partial reperfusion, the goal is to balance the reperfusion versus the residual perfusion. So here, there's a little bit of clarity. It's around 140 to 160. But in complete or failed reperfusion, higher pressures may be necessary to sustain collateral flow. Although definitive thresholds are not yet established, we have to be clear with that. This physiology-driven approach is increasingly being adopted in neurocritical care units. After stroke, cardiac dysfunction is common and can manifest as arrhythmias, myocardial injuries, and reduced contractility. These impair the heart's ability to generate forward flow. Even if you have adequate blood pressure, if your cardiac output is low, there would be no forward flow. That means there is no cerebral perfusion. Ultimately, one must monitor cardiac rhythm, your troponin levels as necessary, and to get your ECGs as needed. If you know your focus for cardiac, then do it. If you have a bedside echo, do it as well to check for baseline and compare it as needed. Volume status determines preload and directly influences stroke volume. Even with normal heart, inadequate intravascular volume can reduce cardiac output and compromise cerebral perfusion. Conversely, excessive volume will cause complications like pulmonary edema. Worse, you're going to put so much volume in your brain, you're going to cause cerebral edema. So the goal here is euvolemia. This is one of those things that in the NCCU or in the ICU, we do not know how to define what euvolemia is. There are lots of things that you can do to check for euvolemic state. COCI, IVC collapsibility, but these are not readily available. So, in practical terms, what you do is to monitor your INOs, check for your balance, cumulative balance, and 24-hour balances, and see if you're going beyond 1,000, plus, minus. Let's talk about the hemodynamics. What matters is what I was talking about a while ago, which is systemic flow, or this is your cardiac output. A patient may have a normal BP, but still have inadequate cerebral perfusion if forward pressure or flow is impaired. Remember, flow does not equate to perfusion. This is why after reperfusion, restoring the artery is only part of the equation. You have to make sure that your systemic flow is also good. Check your hemodynamics, check your cardiovascular state. Let's move forward. Let's talk about cerebral physiology targets. How many here, when you go to your rounds, see patients in the stroke unit and you see everybody is using nasal cannula and on face mask and providing oxygen therapy? Is this really necessary? As for me, when I do rounds, almost everybody is an O2 therapy. You see, oxygen should be viewed as something that is titratable. It's a medication, meaning it has a side effect and it is very beneficial as well. While hypoxia clearly worsens ischemic injury by reducing oxygen delivery, excessive production or provision of oxygen can cause oxidative stress and contribute to blood-brain barrier disruption. This is particularly relevant after reperfusion, where your ROS or your reactive oxygen species play a central role in secondary injury. Therefore, the goal is normoxemia or normoxia, while avoiding unnecessary high oxygen levels. What's the practical target? 94 to 98%. You do not need to have 100% all the time. Reduce your O2 supply. Nakakabawas yan sa gastos. In one of the hospitals, they measure it per hour. Okay? So O2 supplementation is necessary if needed, but if not, taper it and remove. When ICP is high, neurologists, what do? We hyperventilate. We make use of ventilation. We make use of CO2. Because carbon dioxide is one of those powerful and rapidly acting regulators for cerebrovascular tone. Changes in PaCO2 directly alter cerebrovascular tone. Hypocapnia, less than 35 millimeters mercury, will cause what? It will decrease your cerebral blood flow because it will vasoconstrict your blood vessels. So much so if you have PaCO2s of more than 45 that it will cause vasodilation. And this can lead to high cerebral blood flow and can lead to edema. After reperfusion, autoregulation is often impaired, making cerebral blood flow particularly sensitive to CO2 and BP changes. As a result, even a small change in your PaCO2 or your blood pressures, it can significantly change your perfusion. The clinical goal is therefore strict normocapnia. That is 35 to 45. In some literature, they would go for 35 to 40. Avoiding both hypocapnia and hypercapnia is then necessary for post-reperfusion period. Everyone is familiar with this one. We've seen this in Adams or some of your books when it comes to neurocritical care. This is your Lassens curve. Under normal circumstances, the cerebral vasculature can maintain a constant cerebral blood flow with wide map range. Changes in CO2 and your blood pressures do not really change your cerebral blood flow unless they are problematic or high above the targets. However, after reperfusion, it is known that your autoregulatory responses are impaired, meaning small changes in these parameters can cause massive effects in your cerebral blood flow. So the target, you avoid extremes in MAP and your PaCO2 levels, maintain stable physiology, and of course, you have to make use of these parameters to individualize your management in patients. Now, let's talk about cerebral edema. This is one of the most important drivers for clinical deterioration after reperfusion. As the blood-brain barrier becomes disrupted, vasogenic edema ensues or develops, and this process is further amplified by inflammation. Physiologically, rising intracranial pressure reduces your cerebral perfusion pressure. As neurologists, trainees in neurology, or all allied medical field, we have to remember that cerebral perfusion pressure is equal to MAP minus ICP. Sometimes we forget this. That means that we have to balance the ICP and MAP to target a specific cerebral perfusion pressure. And by far, there are no guidelines that would say that this is the target. There is none. But in practice, we target 60 to 70 millimeters mercury of CPP. Moving on, let's talk about the cellular and metabolic targets. Temperature. Temperature plays a critical role in modulating reperfusion injury in the early post-stroke period. We all know if a patient has fever, what happens is that there is increased cerebral metabolic demand, and there is also increase in the usage of your oxygen. And that worsens inflammation, disrupts your blood-brain barrier, and eventually it can cause edema. Of course, all these will proceed with bad outcomes. This is very interesting in literature. If you lower down temperatures of individuals, will it really change the outcomes of patients? If you try to lower down temperature, the cerebral metabolic oxygen demand and the metabolic demand in itself decreases. So this is interesting. But studies, observational studies at that, would say that there is no functional benefit to lower down temperature to 30 to 35. However, what's necessary is that we have to target normothermia. And if ever that your patient would have fever, more than 37.8 degrees Celsius, be aggressive in lowering down these numbers. give paracetamol, make use of your convection, conduction, and all methods of reducing your temperature. Strict glucose control is important in the reperfusion period. Glucose is a major metabolic amplifier of reperfusion injury. In the setting of acute ischemic stroke, hyperglycemia, as we know, is already proven that will produce bad outcomes. In practice, our goal is to target 140 to 100 milligrams per deciliter. Some patients would have fluctuations in their sugar levels, but these needs to be monitored. In practice, we make use of your regular insulin as sliding scale if you are going beyond the target. Prepare for D50-50 if your sugars are going down. Now, let's talk about hemoglobin. There is overemphasis in the use of your oxygen, but there is no use in giving high oxygen levels or adequate oxygen levels if you do not have vessels or a method of bringing this oxygen to your brain or end organ. So that is your hemoglobin. Oxygen delivery is a function of cardiac output and arterial oxygen content, meaning that even with normal oxygen saturation, anemia can significantly reduce the oxygen reaching the brain. This is particularly relevant in the reperfusion period because the reperfusion period is where oxygen is always needed. Clinically, what do we do? The goal is to avoid significant anemia and maintain adequate oxygen carrying capacity. By all means, transfuse and give your blood products if the hemoglobin levels are less than 7. 8 to 10 will be a trigger for you to decide if you're going to give your blood transfusion. More than that, it's adequate, it's fine. Now we're coming to the last 2 slides. When talking about cerebral autoregulation, I often show this figure because it's very interesting. It just gives us an idea of what's happening to the brain. This incorporates the effects of your PaO2, your PaCO2, and your cerebral blood flow and your MAP. This emphasizes that cerebral blood flow can be affected by multiple variables. Blood pressure, as you can see here, can affect your cerebral blood flow. The cerebral blood flow is maintained perfectly and adequately with MAPs of 60 to 150. More than 150 of MAP, you're going to have increase in your cerebral blood flow. And less than 60 would cause decrease in your cerebral blood flow. Now let's talk about your PaCO2. As you can see here, the range is just very narrow. It's 35 to 45. If your PaCO2 level is less than 35, you will have drastic decrease in your cerebral blood vessel. So there will be decrease or constriction. So that will produce decreased cerebral blood flow. Further down the line, it will cause ischemia. That's why hyperventilating a patient for very long periods of time is also detrimental. Now, if you allow CO2 to remain more than 45 millimeters mercury, it will cause vasodilation and eventually can cause increased cerebral blood flow and eventually edema. Now let's talk about your PaO2. Your PaO2 should be maintained around more than 50 millimeters mercury at all times. If it's less, as you can see here in the image, there is a sudden surge of vasodilatation. This is a compensatory mechanism of the brain when it detects that there is decreased PaO2 in the system because it likes to drive more oxygen to the brain. Now what's coming? Well, clearly what we're seeing is that there's a shift away from viewing reperfusion as a binary event. Mali ako no medical student ako na sinabi ko na pagka inalis ang bara, yun na yun. Madami pa palang nangyayari pagkatapos. There is now an increasing focus on thromboinflammatory mechanisms, particularly platelet immune interactions and neutrophil extracellular traps. At the same time, therapies targeting blood-brain barrier integrity and edema, such as your SUR1 TRMP4 pathway and your MMPs. These are actively being investigated right now. And lastly, focus on reperfusion quality is increasing, not just on recanalization. To end my talk, I would like to say that artery may be open, but the outcome is determined by what happens next. Thank you very much for listening.
Thank you, Dr. Manolo Kristoffer Flores. And now, let us welcome our fourth speaker, Dr. Elbert John Layug.
Good afternoon, everyone. Thank you very much for the kind invitation. It's truly a privilege and an honor to be here speaking before a distinguished group of professors and colleagues whom I hold in the highest regard. Today, I will be discussing pediatric ischemic stroke, an area that continues to challenge many of our traditional concepts in stroke care. Before I begin, I'd like to state that I have no conflicts of interest to disclose. So for the next 20 minutes, I aim to contrast pediatric and adult ischemic stroke, identify key diagnostic challenges and stroke mimics unique to children, evaluate the limitations of extrapolating adult stroke, and integrate a practical pediatric framework into the existing stroke systems. To start the ball rolling, I'd like to share two brief clinical pearls. The first is a newborn presenting with lethargy, examination non-focal, treated routinely as a case of HIE, run-of-the-mill. Cranial ultrasound, unremarkable. 2 years later, early hand preference begin to emerge. And eventually, the child presents with hemiplegic cerebral palsy. In the ideal setting, this could have been caught earlier. This is pediatric stroke. Missed not because it's rare, but because it looks different. The second, previously healthy 6-year-old boy, had a recent upper respiratory infection about 2 to 3 weeks prior. Presents with sudden focal seizure. Seizure, run-of-the-mill in pediatrics, followed by right-sided hemiparesis. At first, this is thought to be Todd's paralysis, and so no immediate stroke pathway is activated. But when the weakness persisted into the next day, imaging is finally performed, revealing an arterial ischemic stroke. This is pediatric stroke, not delayed because we lack treatment, but because we did not recognize it. We've just seen two different presentations, a newborn with non-specific lethargy, recognized only years later, and a child with a seizure and weakness, initially mistaken as Todd's paralysis. These are not outliers. They represent the two typical phases of pediatric ischemic stroke. On one end, perinatal, often silent, diagnosed in retrospect. On the other, childhood arterial ischemic stroke, more acute, but still prone to delay. With that framework in mind, the next question is, how common is this? Natanong ng mga tao sa akin, anong ginagawa mo sa Toronto? This is the bulk of my work. To appreciate it properly, it helps to look at stroke across the lifespan. So on a log scale, although childhood stroke appears distinctly lower, perinatal stroke approaches the same order of magnitude as adult stroke, something we often underestimate. So this gives us a clearer perspective on where pediatric stroke truly sits in the aspect of arterial ischemic strokes. Now, across the lifespan, stroke etiology shifts dramatically. In the perinatal period, mechanisms are largely embolic and peripartum related. In childhood, arteriopathy becomes the dominant driver. And in adults, stroke, as of course you all very well know, atherosclerotic. So while we use the same term ischemic stroke, the underlying biology is fundamentally different. Allow me to briefly highlight perinatal arterial ischemic stroke, not only because of its epidemiologic burden, but because of its very unique clinical nuances. In this subtype of pediatric stroke, up to 70% is actually placental thromboembolism by mechanism. We are also faced with the uncertainty in the timing of the injury. Maybe it happened around labor, during delivery, or maybe a little earlier, maybe less than 7 to 10 days, that upon clinical presentation at birth, you'd still catch the diffusion restriction. With this, there is no last known well, and the clinical manifestations are very nonspecific, that they are commonly missed, particularly in limited resource setting, as HIE, neonatal sepsis. Aside from the unknown timing of occlusion, the difference in neonatal physiology limits extrapolation of data to this age group for thrombolysis and thrombectomy. Examples include the very fragile vasculature, the normal physiologic difference in the neonatal coagulation system. Furthermore, there is often not an active occlusion at diagnosis, and injury may already be completed infarct. This is also that realm of ischemic stroke when secondary stroke prevention is limited. In majority of the cases, by the time the patient is delivered, the presumed risk factors are also virtually separated from the baby. So placenta, being the predominant risk factor, is already separated. In utero infection, hemodynamic stresses of labor and delivery, thus the role for secondary stroke prevention is limited, except for a few, those with congenital heart diseases and or hereditary thrombophilic disorders. Because of the immature neurovascular unit and heightened neuroplasticity, the neonatal brain responds to injury differently, so shifting therapeutic strategies towards neuro repair and regeneration, as exemplified by emerging trials such as the Dinosaur and Passion. So I've been involved in the ongoing Dinosaur trial, which is investigating darbepoetin, an analog of erythropoietin, a neuroregenerative strategy in which patients with neonatal arterial ischemic stroke are being given this drug to allow neuroplasticity. It's still an ongoing study, and we hope to get preliminary data in the upcoming IPSO convention this year. The other one is the Passion study. It's a study from the Netherlands led by the Utrecht neonatal group. It investigates intranasal delivery of bone marrow-derived mesenchymal stem cells as a regenerative therapy for neonatal stroke, with early studies demonstrating safety and feasibility. So this too represents one of the first translational attempts to move from neuroprotection to true neuroregeneration in neonatal stroke. Now, while we're awaiting for the regenerative therapies to mature, current management remains rehabilitation focused, especially the constraint-induced movement therapy in children, which promotes use of the affected limb. As shown in the video, this therapy tries to force the use of the hemiparetic limbs. How do you do that with the child? Try to restrain the one that's normal and allow to do play activities for rehabilitation, pushing neuroplasticity to do its job, but constraining the movement of the normal limb. So the earlier, the better. This highlights why earlier identification of neonatal stroke is critical, as it allows us to anticipate which infants are likely to develop hemiparesis and benefit from early targeted intervention. Survival from perinatal arterial ischemic stroke is high, but it carries lifelong risk of hemiplegic CP, epilepsy, cognitive and behavioral sequelae. So high survival, but high morbidity. Let's move now to the next category, childhood arterial ischemic stroke. But before that, let me anchor this with a case. This is a 10-year-old boy, recurrent episodes of dyspnea, initially managed as bronchial asthma in the primary care setting. On the day of consult, he presented with acute left-sided hemiparesis. ACT parenchymal scan was read as normal, but importantly, vascular imaging revealed a right MCA occlusion. He was given intravenous thrombolysis and was rapidly transferred to our tertiary children's hospital for endovascular thrombectomy. Apparently, the dyspneic episodes were cardiac by nature, and the child has restricted cardiomyopathy, being given by primary care with salbutamol nebulization as needed. Because of timely recognition and successful reperfusion, the child had complete neurologic recovery. Because of this, he was prioritized first on the line for cardiac transplantation and underwent a successful transplant just a month later. This case highlights a critical point. Code stroke is applicable in children. But how do we actually operationalize this in practice? Because while the principles of rapid reperfusion are shared with adult stroke, the pediatric code stroke pathway is fundamentally different, more cautious, more selective, highly individualized. So let's briefly compare how these pathways diverge, and let me highlight clinical nuances of the childhood AIS as we go along. First, let's look at the etiologies of CAIS. As mentioned earlier, arteriopathy is the most common reason. Moya-moya, genetic arteriopathies, focal cerebral arteriopathy, infectious causes. But if you look further, we understand that this condition is non-atherosclerotic, very different entity as that in adults, which makes extrapolating the adult code stroke to the pediatric code stroke a bit more complicated. Even the cardiac etiologies are not similar. We're talking about congenital heart diseases, post-cardiac repair, acquired heart diseases in PEDS, RHD, IE, and a genetic disorder like the cardiomyopathy described in the case. So given these varying etiologies, let's take a look at the clinical manifestations. In adults, stroke is classically focal, fast or be fast, lateralizing signs. In children, stroke is frequently non-specific, seizures, headache, vomiting, altered sensorium. And importantly, stroke mimics dominate the pediatric presentation. So the pediatric neurologist is often asking, is this stroke? While the adult neurologist, you guys, would be asking, how fast can we treat this stroke? So mimics are so common such that in one study, 70 to 80% of pediatric code stroke activation are actually due to mimics, 70 to 80%. And up to 80 to 93% of the acute focal deficits in children are stroke mimics. And these are predominated by migraines, particularly hemiplegic migraines, and seizures with Todd's paralysis, and as flashed down the line. With such nuances, pre-hospital recognition complicates the things in pediatrics. In adult stroke, pre-hospital systems are good. Fast, EMS pre-notification in developed countries, but in PEDS, there's no validated pre-hospital screening tool. Adult tools underperform significantly in children because of the high mimic burden. Let's say the child is fast positive, but that's a low positive predictive value because 70 to 80% are mimics. Moreover, FAST is also blind to the red flags in pediatrics, like symptom of seizure, headache, and behavioral changes, which are the predominant manifestation in pediatric stroke. In adults, activation is time window driven, 4.5 hours for thrombolysis, extended windows for thrombectomy. In peds, it's often symptom-driven, not strictly time-driven. So you'd see that some institutions activate up to 24 hours from the onset. And even though focal neurologic deficit is being used as a parameter, we've pointed earlier that 80 to 90% of these are actually mimics. With these circumstances, we tend to under-triage, wherein we do not recognize stroke leading to delayed imaging. We also over-triage. There are too many mimics, which may lead to unnecessary code stroke activation. While the adult system prioritizes speed, pediatrics need to make sure of diagnostic accuracy. And this is what leads to one of the biggest paradigm differences. In adults, CT first, fast, accessible, rules out hemorrhage. But in children, we often preferred MRI because it's more sensitive, it avoids radiation, it helps differentiate the mimics, 70 to 80%. But MRI introduces delays, availability issues, sedation requirements, and other logistics issues. As we've mentioned, pediatric stroke trades speed for accuracy. In adults, thrombolysis definitely standard of care, decades of RCT data. In pediatrics, we have no robust RCTs. Most decisions are extrapolated from you guys. So every time we give TPA in a child, we are actually practicing evidence-informed extrapolation, not evidence-based medicine. Mechanical thrombectomy is transformative in adult stroke. In PEDS, it's emerging, but evidence is still limited to case series and registries. And important to note that the safety profile for this does not differ from the adult RCT experience. In adults, we leave biometrics, door to needle, less than 60 minutes, CT within 25. In children, given the aforementioned factors, can be activated up to 24 hours in practice. So where are we now? We have no standardized pediatric stroke pathways globally, no validated pre-hospital tools, limited hyperacute therapy data. And yet, we are expected to make time-critical decisions. Major gaps, lack of RCTs, lack of standardized pathways. But it does not stop there. Thankfully, the pediatric code stroke pathway is already emerging in multiple centers around the world. This is not theoretical anymore. They already exist. And allow me to just briefly highlight a few. So flashed here on the screen is the pathway by Toronto Sick Kids, the pioneer in pediatric stroke care. We'll not go into details, but just to highlight that the pathway basically extrapolated practices from your adult space, from identification, activation, and ongoing neurocritical care aspects of care. And just to highlight that the cutoff age of sick kids, given being the pioneer and years of experience, they would at least activate code stroke, at least 2 years old, within 24 hours of symptom to be candidate for the reperfusion therapy. And we have here the one from the Philippine General Hospital, protocol implemented just last year by my mentor, Dr. Marilyn Tan. I was still in abroad when they made this protocol. This was made possible, of course, with the help of our amazing adult strokologists in the institution. So as we are still on beta testing, the center opted to open the BAT in peds for ages 12 to 18 years old. Also just highlighting that we strive to get an MRI when the pediatric code stroke is activated, considering all the circumstances mentioned earlier. As of the moment, we have had 17 activated code strokes since March of 2025. Half of these were through strokes in children, but did not meet the inclusion criteria for reperfusion therapy. So we'll try to improve as we go along. Now let's look at the outcomes. Although randomized data are lacking, registry evidence consistently show that children who receive reperfusion, particularly for LVO, have higher rates of good functional outcomes and lower disability compared to those who do not. So even without RCTs, the signal is consistent. Remember, this is a child with decades of life ahead. Identifying that one child early on is significantly life-changing. Rare, varying etiologies, unique presentation. So how do we actually integrate pediatric stroke into the adult stroke system? We definitely would need your expertise in this endeavor. And some tips for practical integration. Key is not to build a separate pathway. You have to modify the existing ones. First, at the level of recognition, we expand our triggers beyond FAST to include seizure with TODs and atypical presentations. Second, activation becomes more flexible, symptom-based rather than strictly time-based. Third, imaging shifts towards MRI when feasible, while retaining CT for unstable patients. And finally, treatment decisions, particularly thrombolysis and thrombectomy, they are individualized, but still anchored on the same principles of reperfusion. So the goal is not reinvention, but integration of the things you've already mastered. Childhood stroke sits at the intersection of pediatric and adult stroke paradigms. Unique biology persists, but reperfusion strategies may be applied in carefully selected cases. It demands a more nuanced approach, balancing urgency with diagnostic precision. So to wrap it up, ped stroke, not a smaller version of adult stroke, actually presents two distinct entities. You have the perinatal, makes up a significant proportion of our job, often not amenable to reperfusion, and this is where emerging neuroregenerative strategies are beginning to leverage the neuroplasticity of the neonatal brain. Childhood stroke, challenge shifts where diagnosis rather than treatment becomes the primary bottleneck. Existing pathways already exist. What we need is not reinvention, but thoughtful adaptation into our current systems. And ultimately, the goal is simple: to recognize early enough to change a lifetime trajectory. These are my references. Thank you for your attention.
Ayan, hindi nyo na ako ulit kita. Ho. Top na lang ulit ng head ko. But that's okay. Thank you to our speakers. You all delivered very comprehensive and very concise talks that gave us so much insight about acute and subacute therapies in acute stroke. I would like to open the Q&A now. Those who want to ask your questions live, please approach the microphones that are around the ballroom now. And again, you can also use the QR code if you are too shy to ask your questions live. But habang naghihintay, I would like to start the ball rolling. I actually have a question to Lennie. So, given the growing use of Tenecteplase, and because it is now now we know that it's superior in terms of efficacy with almost the same safety profile as Alteplase. Is there still a subset of patients who you will give Alteplase to? And what kind of patients would these be?
That is a very challenging question, ma'am. Mostly, I think the answer would be kanino kaya mas okay yung Tenecteplase? Because we know that Alteplase is very efficacious for all types of AIS. So, by experience, but this is not evidence-based because there are no studies really when to choose Tenecteplase over Alteplase. We usually use Tenecteplase if it's LVO, so large vessel occlusion, because there is evidence for that. And also, in pursuit of time, pagka malapit na sa 4.5 hours, very difficult to reconstitute Alteplase, so we use Tenecteplase. So those two things are the usual scenarios kung kailan po kami nag-Tenecteplase over Alteplase.
And in connection to that, because there's a question from the audience, Lennie, and I think you can answer this best. Why would TNK be better for LVO stroke?
That's a good question, but most of the studies on LVOs are small. Kaya it's very also kailangan cautious din tayo in interpreting them. Kasi dun po sa meta-analysis, around 400 lang yung patients. Out of the 7,000 patients na na-study nila for Tenecteplase, around 400 lang yung LVO. So, I'm not sure, no, bakit dun sa study na, dun sa apat na study, there are only 4 RCTs in that meta-analysis. So, maybe because the sample size is small,
Right.
so we cannot really extrapolate. No? So, but those studies are somehow, ano naman sila, reputable studies. So, we can prefer Tenecteplase for LVO if that's the case po. And maybe because din po, most of the time, LVOs, sila po yung nagtathrombectomy. And they saw na yung workflow for the Tenecteplase also works better for thrombectomy patients.
Thank you, Lennie. I think what is good in the trials nowadays is that it looks at the different etiologies of stroke and that the therapies are not parang lumped together, no? Parang hindi siya for all etiologies, and that is actually very good. That now we recognize that etiology is very important. There's another question from the audience. Tope, will you still recommend hypothermic protocol for an arrested patient?
This is a very good question and an intriguing one because a few years ago, let's say 5 to 10 years ago, we've been trying to protocolize everything that if there is an arrest out of hospital or in hospital, depending on the rhythm of the arrest, we will do hypothermic. And the targets then were 32 to 35 degrees Celsius. But recent studies would negate this. The move is that guidelines would say we will target normothermia and prevent fever. It looks like that we are trending to a 36 to 37 degrees Celsius. Other than that, we are sure that febrile episodes will worsen outcomes, but below that, like 35 and below, it wouldn't really have a big impact. So will I recommend the hypothermic protocol case-to-case basis, but I will not go down to at least 32 to 33 degrees, not anymore. I would go to 36 degrees. 36 degrees is the safest. Thank you.
Thank you, Tope. Yes, sir. Dr. Navarro po.
Question goes to Dr. Torres. Well, congratulations for the program that you have done in Davao. And probably you're still a medical student when I went to Davao to give that lecture among your EMS. Now my question goes like this. Have you considered doing a spoken hub in Davao? I think this will be more effective than the rest of the program that you have just discussed. Because the program you have discussed is limited only in one hospital. But if you do a stroke and hub, you'll be able to cover the community.
Yes. Thank you for the question, Dr. Navarro. So actually, Doc, we are fortunate because Dr. Escabillas took some time off. He will be going to Davao in April 17 po to discuss actually the spoke and hub model. Dr. Escabillas, Cyrus, Doc. Yes po. So we talked about that late last March, and then we planned it out. So hopefully we can implement the spoke and hub model so that during our previous discussions among the ASRH and with the Davao Central 911, the problem now is that they would prefer to send patients, triage right away to SPMC. Why? Because that is under the mandate of the local government. So they have no choice. They have to send those patients who called them diretso sa Southern Philippines Medical Center, which is the Apex Hospital there in Southern Mindanao. But now, we are hoping that we can talk with the local government to revise that mandate so that we can bring the patient to the nearest thrombectomy-capable center. So we are very fortunate because we have several vascular interventional neurologists as well as endovascular neurosurgeon who will help us with more or less implementing the spoke and hub model in Davao City. And hopefully we can expand that further to Davao region. So that's the plan moving forward po, sir.
Furthermore, I think this goes also to our audience. Remember that the applicability, even of thrombectomy, is only less than 10% of the patients with ischemic stroke. If you put up a stroke unit, 83% of your patients can be eligible in your stroke unit. And then now you have the stroke and hub, that goes up, the applicability of the process and all these things that you're doing for stroke patients will go high. So it's a little more applicable, I think, at the end, less expense, and then you'll be able to administer urgently what is needed for a stroke patient.
Yes, sir. I completely agree po, sir. The problem with private hospitals, of course, kasi we all know it's a private hospital. So, of course, income-driven. So, we have some barriers with the administration in implementing the acute stroke units. So, out of the 6 acute stroke-ready hospitals, actually only 2 have the acute stroke unit. And even the government hospital, we have been having a problem haggling with the administration to put up an acute stroke unit for us. But more or less, because of the implementation of the acute stroke-ready hospital program, most of our residents, internal medicine residents, nurses are now trained for management of acute ischemic stroke in the hospital. So we've seen that in the programs when the acute stroke-ready hospitals reported during the last assembly. So that's why I'm so happy that our thrombolysis rate is higher compared to the published 11% yet for the national level. Thank you.
Thank you, Julie. Any more live questions? Dr. Layug, I do have a question. I remember last week, or was it the other week during the grand rounds at Asian, we were talking about pediatric stroke and how different it is from an adult stroke. Is there a difference in terms of recovery and in terms of plasticity? And what are the things that we can do to actually improve recovery?
So, yeah, good question, Doctor. Actually, I've pointed out also last time that the younger children are actually having this higher neuroplasticity. Okay? As I've mentioned earlier, the perinatal stroke space actually has a good evidence in terms of good outcomes for children. So, theoretically speaking, the younger children are actually more prone to full or good recovery compared to adults, given the functional recovery, if you'll base that on data. We could cite a lot of perinatal arterial ischemic stroke studies showing that you have that particular large MCA infarct but the child looks well. No signs of hemiplegia. Maybe not an honor student in class, but you don't see hard deficits at all.
Thank you very much. If there are no more questions, I am sure that, because I see there are more questions actually sent through the QR code, but in the interest of time, we will have to cut. I am sure that our distinguished speakers will be available to answer your questions if you approach them personally. This afternoon, we looked at topics and a clear story emerged that in acute stroke, we need to be evolving not in pieces but as a system. So first, Dr. Julie talked about pre-hospital triage, and because in our setting, recognizing stroke early and getting the patient to the right place quickly can be just as life-saving. Number two, we talked about deciding between Alteplase and Tenecteplase, not just based on global evidence, but on what is practical, on what is available, and what is sustainable for the Filipino patients. And then we moved to Dr. Flores' discussion of neurocritical care in the first 48 hours and the things that we need to do to prevent and manage reperfusion injury, which can actually differentiate between recovery and disability. And very important, now we have to be reminded that strokes not only occur among adults, they do occur in the pediatric population, and that we need to talk about pediatric stroke codes because they're a little more, they present more differently compared to the adults. And we have to put in systems that must be flexible, inclusive, and ready for the unique challenges that pediatric strokes pose. So put together, these topics highlight something that is powerful. Stroke care is not one breakthrough. It's a chain of well-coordinated decisions that need to be adapted to the local context. And when that chain works, we don't just save lives, we preserve futures. Maraming salamat po for listening and being with us throughout the second session. Please stay put for the next session. Thank you.
Thank you to our speakers, Dr. Julian Kristy Torres, Dr. Lennie Lynn de Castillo, Dr. Manolo Kristoffer Flores, and Dr. Elbert John Layug, and to our moderator, Dr. Jennifer Justice Manzano.